Good afternoon, everybody. I want to welcome you all here to the Board of Associates meeting, the Lehigh Valley Board of Associates, the Pocono campus. Lehigh Valley Board of Associates has actually been around for 25 years, and I know some of you were here at our meeting in April. For those that were not, I'd like to tell you just a little about the Board of Associates. It is really a way for us to connect with the communities that we serve, and it consists of members who are business leaders, who are community influencers, and it's those who have a sincere interest in helping us keep our communities healthy. We will talk to you today about the state of community health. You'll hear about innovations in technology from some of our leaders in the medical field, and we're going to hope that you share this information with your friends and colleagues in the community, and at the same time, we ask that you bring feedback back to our Board of Associates, which is then sent to the top. And there is no one more at the top than one of our speakers today. We will have three people speaking. The first is Elizabeth Wise, who is the president here at Lehigh Valley Hospital Pocono. She will talk about the Pocono region. She'll then be followed by Brian Nestor. Dr. Brian Nestor is our CEO of the Lehigh Valley Health Network. And finishing up will be Dr. Suresh Nair, who is the physician-in-chief of the Lehigh Valley Cancer Institute. It is now my pleasure to introduce Elizabeth Wise.
It's okay to clap. Thank you very much for taking your time to spend with us. Most importantly, for us to share information, but really for us to hear from you or give you the opportunity to ask questions, because you are our ambassadors in the community to be able to share with our community, yes, that's right, or no, that's a rumor. And I'm in the know, and let me tell you what I do know. So I just want to say thank you for your time. I just want to give you a couple updates of things that are happening here that we're very proud of. I'll start out with, we are always focused on quality and safety and how we can continue to be a high quality provider for all of you across the care continuum. I am proud to say that we received recognition from the Leapfrog Group, which is a group of businesses that partnered to take a look at outcomes and certain metrics and processes that you need to have in place in the hospital. And we just received our 7th A. So I am thrilled to be able to put two hands up to say, you know, our 7th A in Leapfrog. And we're recognizing that through a number of different ways. The other things that we just got reaccredited as a primary stroke care provider so that patients who are having a stroke can come to our facility so we can treat them. And we have very good outcomes associated with that. And the other thing from a quality perspective, we were recognized by the American Heart Association for something called Get With the Guidelines. And that's really what is the latest research and evidence that if a patient comes into your facility that's having a heart attack or a cardiac condition, that you always do these things. So we received the Gold Award for what's called Get With the Guidelines from the American Heart Association. We had a ribbon cutting ceremony last week to reopen Hospice House. So we had two different events. One was with the press we invited in, as well as some of our board members were in attendance, our community that's working with us to raise philanthropic funds for the house. So we did a ribbon cutting ceremony. And then the second night we had an open house where we invited the community to come in. We've done some renovations there, some painting, some replacement of our beds, and had a very good turnout and reception associated with that and got some very good feedback. The house is not officially opened yet, and I'll just tell you the process that's involved with this is we have invited the Pennsylvania Department of Health to come in to survey the building, one from a life safety perspective, but also they take a look to make sure our policies and procedures and things are in place. So we have offered some dates to them. We're waiting to hear from them. So once that review takes place, the inspection, then we will reopen the house for our patients and our community. We continue to recruit providers to this area, and I want to mention a couple hires that will be new and somebody who will be returning. We have hired an ENT provider. Dr. Sorotnik will start with us in September. We have also hired a gyne-oncologic surgeon. Her name is Dr. Kim. She is robotically trained and will be here at Pocono, obviously with our Dale and Francis Hughes Cancer Center. And the other person that's coming back to us is Dr. Fuzesi, who is our cardiac surgeon, who is coming back to the community, and he will start in August. We also continue to provide or recruit for primary care, family medicine, and other specialties where there is a need in our community. You know, I always talk about the advantage of our agreement with Lehigh Valley Health Network was that services would stay in this community, and we would continue to provide and recruit so that the services could maintain here in Monroe County. Just want to mention one last thing of where we continue to partner and give back to our community, because that's very important to us. We just had, I say it's my second favorite day of the year outside of my wedding. I have to say that. My husband usually shows up for this day, but we did a grants and scholarship award ceremony where we gave back from out of 12 funds $182,900 back to our community of nonprofits so that they can use those grants to continue to provide services. We also gave out scholarships. So not only for nursing students, but for all other healthcare allied providers that need help to go back to school, nurse practitioners, physician's assistants. And I'm looking out in the room, and many of you are involved in that, and I thank you very much for your contributions and helping to partner with us. And then one last thing I want to mention with partnering the community, which I think is pretty cool, is called Stop the Bleed. And many of you know that we've had some tragic events that have happened in our schools with shootings. And one of the things is that we've done is something called Stop the Bleed, where we've handed out Stop the Bleed kits for every classroom in every school in Monroe County, 2,500 kits. And that not only involves handing out the kits, but it also involves education and training to our teachers and educators. Our trauma service has provided that and has done a lot of education and will continue to do that. Some of those funds came from our foundation that provided the funds to be able to pay for the kits. And we've also provided tourniquets to our school police and security as well, so that should they need them, they're available, and as well as they get trained on it. I'm going to stop there to turn it over to Dr. Nestor, but I'll be available for questions afterwards if anybody has any for us. Thank you. Welcome, Dr. Nestor.
So, hello. Initially, I was thinking that I had an hour to give you a talk, so I have 47 slides. I talk fast. But that's not going to work today. So I'm not going to have any slides. All right, I'm going to boil it down to a couple of stories, all right, that I think represent who LVHN is and what that means to your community here. And then again, take some questions at the end. But knowing that Dr. Nair is here, thank goodness, to talk, I mean, and one of my favorite people literally in the world, I want to make sure that he has time to share his story of what's going on up here. So let me get right to some of the stories, and I want to kind of get at it, to hit the elephant in the room of competition in Monroe County. Okay, this is a long journey. This young lady here, Elizabeth Wise, is my 5th CEO at Pocono that I've worked with in the last 21 years. I would say she's the best, no doubt about it, okay? But there's been a long history of Lehigh Valley Hospital wanting to work very closely with Pocono. It's been a journey, and there have been starts and stops, and there have been successes, many successes that have been under the radar, all right? Ultimately, it was enough to actually create a relationship that when we both look, both Pocono Medical Center, Pocono Health System looked at the future and said, what the heck are we going to do? We were at LVH, we're also saying, what the heck are we going to do? We knew that we would be coming together to give a little bit of strength behind a mission of bringing 1 + 1 together to equal 6. And I think we're both very happy that we did that. So, but why'd we do it? All right, so let me give you a couple stories and some stats to kind of drive the point, all right? Because there's a fundamental difference between what Lehigh Valley Health Network is about and what our competitor, St. Luke's University Health System, is about. By the way, they're a good organization. They provide good care, all right? We believe that we provide great care, okay? And there is a difference in terms of your methodology and your thought process for how you deliver that care for your community into perpetuity, all right? Our mission, it's like many others, kind of, okay, to heal, comfort, and care for the people of our community by providing advanced and compassionate care. Right there, it sounds like every hospital's mission statement of superior quality and value. We've been talking about value for at least 18 years that I've been at Lehigh Valley Health Network. We've been using the value equation, V = Q / C, all right, to make decisions. That superior quality and value has been in our mission statement for a quarter of a century. So when the federal government starts talking through the Affordable Care Act about value-based reimbursement, we're all in. It's about value. And value is driving higher quality at a lower cost. So let's get to the punchline here. The problem in America is affordability. That is the #1 problem we have in America in terms of patients getting good care and access to care. It's just not affordable for most Americans, period. And guess what? As we say in our small inner sanctum, as we're thinking about strategy, we say, guess what? It's going to get worse before it gets worse. This is a bad road for health care in America. There's no way around it. And I'm going to try and convince you of that unless you do something different. Okay, and that's what we're doing, something very, very different. And I'll use examples in your own community about how very different our approach is than our competitor. By the way, competitor, rarely do I ever use that word. You know, we shouldn't be competitors. If we had a sensible American health system that allowed us to rationalize care across counties and regions and block grants with single institutions that, you know, here's your batch of money, take care of these people, do the best you can, you probably wouldn't have. Unfortunately, you don't have it here, but in Allentown, you wouldn't have 4 open heart surgery programs. You might have 2, okay? There's rationalization. Antitrust law doesn't allow that. So as a result, we're made to look at each other as competitors. But by the way, we take care of patients that kind of go to both places, right? So we have to kind of collaborate no matter what. But I would say, for the purposes of our company, we have a better path forward. So let me get to some of those stories. If you think back 54 years on July 30th of this year, all right? There was a birthday. It is when CMS gave birth to Medicare and Medicaid, okay? A long time ago, all right? I'm going to get at this affordability issue, all right? Principally by talking about Medicare. Medicaid's its own problem, all right? It's actually a little bit worse, but not as bad, okay? But we'll talk about that in that hour lecture, all right, when I come back someday. Talk about Medicare. So if you go back 54 years, the lifespan of an American was roughly 67 years of age. I'm going to round it to 65, the closest 5 to have the conversation. So let's use the podium as 65, okay? If you're over here, you're under 65. If you're over here, you're Medicare eligible. So the average age is 65, all right, 54 years ago for a lifespan of Americans. How do we pay for Medicare? Remember? Your taxes, your income taxes. How many American workers 50 years ago were paying into this healthcare investment trust, okay, for every 1 new Medicare beneficiary, okay? 5.6 Americans were working, paying in their income tax, going into this ballooning war chest of dollars to take care of Medicare and Medicaid beneficiaries, okay? People use the word entitlement as if it's a bad thing. It's not. The entitlement programs in Medicare and Medicaid, they're good programs. They're worthy programs. Think about Medicare. Arguably, for a group of people that were arguably the greatest generation. People that fought in world wars, protected our country, helped build the manufacturing and industrialized universe that is an extraordinary economy and globally. How about we give them a little, health care when they finally get in the rocking chair, right? Not a bad idea. For Medicaid, people that are, you know, sometimes just unlucky, okay? They step on a cancer bomb, and that can happen to anyone, and destroy your family because you lose your job and you're not there to take care of other people. That's a problem. Or maybe they just have other social or economic obstacles in the way, all right, that are preventing them from having a life that allows them to access health care. Let's give Medicaid. Good programs, all right? I still think they're very good programs. And it worked really well when everyone, think about Medicare beneficiaries, are dying when they're supposed to, okay? Remember, actuarially, the math from the federal government was when you turn 65, you'll be dead when you get the benefit. Pretty cool, right? The math works. Suddenly, you've got hundreds and hundreds of millions of dollars kind of being accumulated, okay, in this big war chest, only to have, oh, we're about to spend it, he dies, okay? All right, you understand, making the point a little bit exaggerated, but you understand that's why there was so much money there. And then healthcare started to change. Late 60s, you have people that are unzipping your chest, releasing your aorta and tying a piece of vermicelli from the aorta down to the left anterior descending branch and driving new blood into a heart so they save you from another heart attack. I mean, open heart surgery. My goodness, who'd have thunk that? And by the way, we're going to probably do 20 of them today across the network. Probably have a few over here at Pocono right now going on, right? That's just routine stuff. I guarantee you, what's today, Monday, right? They're all a blur, all right? We probably put 5 hips in 90-year-olds across the network. Why? Because they're a good 90-year-old, right? But for their inability to walk, they'd be highly functional, all right? So you can see there's a problem that's occurring. Medicine's getting better now over that course of time. So now fast forward to today, and we're doing all that stuff routinely. And guess what? It all costs a lot of money. So now there's a little bit of a difference here. People are living a little longer. So here's the first story. I always like to talk about my grandfather and my dad. So my grandfather, his name was Leon Lester Nestor. Swear to God. He had a twin sister, Esther Nestor. Swear to God. And they're from Virginville, Pennsylvania. This is kind of like Beverly Hillbillies, right? You know, they're Pennsylvania Dutch that came over in the late 1700s, lived in agrarian society, and then went to 8th grade and then went to Reading because of the manufacturing mills and fabric mills and, you know, got jobs there. And, you know, just that's how it was. But my grandfather, if you look at my grandfather, my father, and then me, we're all exactly alike except that I'm a little taller. So my grandfather had male pattern baldness, okay, creased earlobes, hyperlipidemia, hypertension, insulin-dependent diabetes. He smoked unfiltered cigarettes that I made for him. That was my job. I mowed his lawn and I made his cigarettes. You know, you take a little bugle boy, you put it in the little wrapper, and you lick it when you're 10 years old. It's pretty cool. You know what I mean? Stack them all up, watch him smoke it. What I didn't realize is that was probably contributing to why he was the shiniest person I ever knew. Shiny, what do you mean? Well, his head was shiny with no hair. His arms were shiny with no hair. His legs were shiny with no hair. He wore long underwear in August. He called it the rheumatism. How many people know what the rheumatism is? It wasn't rheumatism. This was peripheral vascular disease. He was a vasculopath, okay? So it shouldn't have been a surprise when I come home from my first semester of college for Christmas break and my dad goes, bad news, Pop had a heart attack. He's in the hospital. After you do your night shift at McDonald's, you can go visit him tomorrow. I came home that night. I didn't feel good about it, and sure enough, he died. I didn't get to see him, right? He died at 62. He died when he was supposed to die. Okay, now keep in mind, this is 1980s, early 1980s, right? How much did that cost the federal government? Nada. Bupkis, right? Because he wasn't a Medicare beneficiary yet. All right, he died when he was supposed to. Okay, make the contrast now. My dad, Leon Lester Nestor, doesn't have a twin. He actually doesn't smoke. He didn't smoke. He does have male pattern baldness, creased earlobes, hyperlipidemia, hypertension, type 2 diabetes, but had the benefit of Lehigh Valley Hospital and Reading Hospital, where he was cathed 4 times and saved, okay? He started living longer than his dad. He actually wound up dying last year this time at age 84 years of age, okay? With 3 active cancers, probably 10 heart attacks total. He just finished his 4th round of radiation for explosive squamous cell carcinoma of the scalp, which is an ugly disease. Doesn't kill you, but it's an ugly disease. he lived long enough with dementia, okay, to see a bunch of grandkids born. And when he passed away the week before, he was playing beanbag baseball with his buddies at happy hour in the skilled nursing facility. How much do you think that cost for him to live 22 years longer than his father? You think that hurt Medicare? My goodness. And as an ER doc, my dad was on 11 medications. He was on 24, but he has an ER doc that can triage. I got him down to 11. They're like, forget this. That ain't gonna, you're gonna die of something else. Forget that. We got him down to 11, okay? And you know, he would call me from time to time, ask medical questions and all, but you know what he never called me about? Hey, Brian, how do I pay this bill? Because Medicare is awesome insurance. You know, no, by the way, it's awesome for the patient. It is not good for the hospital providers, all right? I mean, the subsidy that we have to pay each year is 2/3 of our community benefit across every organization. All right, so put that in context. Our 990s that we have to fill out every year and give to the federal government or submit to the federal government talks about community benefit. What the technical term for that is patient direct care shortfall. It's a financing term. That we show about $550 million of community benefit. That's free stuff we do, like our drive-by shooting that we have down at Coca-Cola Park and Dorney Park, where we have literally the largest mass immunization event in America. 11 to 13,000 people come through in 2 days with 1,000 volunteers and drive up, fill out a form, hand over a can of peas, get shot in the arm, and keep driving. That's the drive-by shooting. We do 12,000 of those in 2 days. That must cost a lot of money. That's rounding error. On $500 million, you know, what does it cost? $20,000? The humans are free. They're volunteers. That's not where the money is. About $350 million of that $550 million is insufficient payment from the federal government for Medicare and Medicaid. Most of that's Medicare. Why? Because people like my dad, who are living longer with many different diseases, and they're going to run us over. Okay? So I'm trying to build up to this financial kind of dilemma that has driven us to take a very different strategic course than our competitor. Okay? So right now, hopefully you can feel that there's a problem with Medicare. By the way, why do I care about Medicare? 7 out of 10 people that will walk in these doors will be Medicare, Medicaid, or uninsured. It's the same at all of our hospitals. 7 out of 10. Our worst payer is no pay. The next worst payer is Medicaid. All right? So we have full-blown Medicaid expansion in Pennsylvania. Medicare is the next worst payer. Okay? And then we have commercial payers, right? Which have their own problems, right? What are their problems? The only way they're dealing with the higher cost of health care is to increase deductibles. So you go to the average family of 4 and they have to pay $16,000 before they even get their benefit, all right? And then the copay is so high that they go, hey, honey, I know you need 3 blood pressure medicines. Can't you lose 20 pounds and just take 1? Sure, that sounds like a good idea because those copays are $90 every 3 months. You're right, let's just not do it. People are making bad decisions with their health, all right? So this is just a dilemma. How do you get around it? Because there's no new money coming. The federal government told us, you're going to take care of more people. You're going to do a better job, and we're going to withhold money, okay, as a quality incentive. And if you hit all of them, we'll give you some of it back, okay? But rest assured, you're going to do a better job to give more people care, and you're going to do it at higher quality. Or, you know, it's all on you. We'll penalize you. Just in case you think we're kidding, bam, across the face. Remember the word sequester? We're going to take 2% of your revenue back. And they did. Okay, so now we're all standing up straight. Yes, got it. All right, we better take this serious. And LVHN did. 2008, Obama's in place. Affordable Care Act, 2010. Not a fan of the Affordable Care Act. But, you know, the enemy of good is great sometimes. You know, Affordable Care at least made us start thinking differently about things. All right? So we started thinking, look, if the federal government someday is going to pay us in alternative payment methodologies or value-based contracts, meaning they're going to pay us principally on our outcomes for our patients, getting people back to functional status, having the lowest possible infection rates, you know, the lowest possible ventilator-associated pneumonia rates. Hey, we're a quality organization. We'll go up against anybody on quality. So let's start chasing that. So we started chasing it. Problem was, how are you going to get paid for it? Because the federal government hadn't figured that out yet, right? So we said, there's no new money coming. The Affordable Care Act has regulated the commercial carriers, because that was the bank we had. Whenever we got less money from the federal government, we go over here and jack up rates with the commercial guys to help offset the losses over here. And that's, if you look at the distribution of our profitability, it is a beautiful, normally distributed graph where we lose money on this side and make money on this side. And the difference is the 2% or 3% operating margin. It's a stupid business. It's a really bad business, right? So we said, well, what's left? Where's the new money coming from? Well, can quality care actually cost less? So we did some experiments. Here's the second story, okay? And it's a cancer story, which will then lead into our speaker today. So if you take this, these were live considerations. We're trying to think through cases to find out how can we possibly provide better care to more people at a lower cost. If we're going to provide high quality care, check the box. We got to do that. How much does that cost? Well, if you take a breast cancer patient, so let's track a breast cancer patient. Jane, she's 40 years old. Her sister died of an aggressive breast cancer at age 33, so she knows she's at high risk, so she's getting annual screening mammograms, which cost a certain amount of money, right? And they've all been normal. This time, she gets a phone call at the house and says, hey, listen, there's a shadow, an 8mm shadow in your left breast. We want you to come back and get a diagnostic mammogram, make sure it's not cancer. So she writes a note to herself, get diagnostic mammogram. We call 2 more times. Keep in mind, this woman is in your life, they're in your neighborhood, they're a family member, okay? Because she's a woman that is single mom, okay, who has 2 kids, and she relies on grandparents, relatives, neighbors, or whatever to get them to and from school. She works middle shift. So she comes home 1 o'clock in the morning, sleeps for 4 hours, gets up, makes peanut butter jelly, and then goes about the same race every single day. Life's busy. Can't fit it in. By the way, where the heck's the copay for the mammogram? Okay, but I don't know. God knows the screening mammogram is enough. Diagnostic mammogram sounds expensive. Okay, so summertime comes because this was February when she got that. She now has 3 Post-its by the coffee maker and 2 certified letters from our office practice that says we need you to get engaged in your care. Come back and do that. And after she gets those letters, we turn our back on her and go about the next 100,000 people that are not engaged in their care. It's just the reality of the business. You can't keep everybody on the radar. Okay? Summertime comes, she goes, oh, thank God I don't have to get up early anymore, make those peanut butter and jelly sandwiches. I'm going to enjoy the summer. But in September, when the kids are back to school, I'm going to get that diagnostic mammogram, right? So guess what happens? Summer goes by, she goes back, gets a diagnostic mammogram. That 8mm shadow, the left breast, is now a 23mm discrete, kind of regularly edged calcific lesion, clear-cut cancer, okay? Why does it matter that's 22mm? Roughly, layperson, not an oncologist, okay? Roughly 20mm is the cutoff, where if it's less than 20mm, an isolated tumor may not have extended to the nodes in the axilla, okay, spread of disease. It might be contained in the breast, but this is 23mm. So guess what? When they did the lumpectomy and found out it was cancer, they then did a sentinel node biopsy. It's positive. The cancer spread. So then they do radical axillary dissection, radical mastectomy, maybe a prosthesis, a little bit of chemotherapy, which knocks her down, beats her up, dehydrates her. She's admitted to the hospital 2 or 3 times until she gets an equilibrium and gets her feet under her after all of this. And she isn't stage 1. She's stage 2 or something worse. And 5 years, she's still alive. Why? Because we have extraordinary things we're doing in cancer now that are keeping people alive, interestingly, long enough for the next big breakthrough. And those next big breakthroughs are coming through with regularity. So she'll probably do okay. But guess what? Breast cancer is approaching 100% cure rate if you catch it in stage 1. So what did we conclude with all this? Well, we did all that stuff to her. 5 years later, she's had 6 PET CTs and 20 consultations and all sorts of new therapies. Maybe they've been through a trial or 2. How much do you think that costs? Millions of dollars. All right? My point to you, there's not enough money in the universe to take care of people and give everybody quality care. So where's the answer? All right, you can see this is getting pretty pointed now. Now we're really up against it. Quality care seems to cost a lot of money. So we're really at a loss. Then we started thinking, there's got to be a way around this because, saying that we're blanked, put your own word in there, is not an answer. Okay, we have to have something, a solution here that will make sure that our hospitals, our campuses, our communities will be taken care of into perpetuity. That's our job as a not-for-profit. So here's where the breakthrough came in. All right, because we love dissecting cases and make sure people get the right kind of care. We decided this time, let's go back and dissect the process, okay? Theoretically, what if we sent those 3 phone calls and those 2 letters and we decided to not turn our back on her but say, we're never going to let her go, okay? Now, it's impossible to do that. You require a miracle because you can't just follow everyone. There's just too many people with all these comorbid problems. But what if we put in place an analytical platform that would actually aggregate all the claims information from every possible insurer, all our ancillary diagnostics, all of our radiology, X-ray, EKGs, laboratory, and all our clinical relevant electronic medical record data points. Put it all in one utopic database. So then Jane shows up in there, and she shows up, the office visit, diagnosis, family history, high risk, has a BI-RAD2 finding on screening mammogram, red alert. Then 6 weeks go by, no claim paid for a visit back with the doctor's office, no claim paid for the diagnostic mammogram. Suddenly we have intelligence that's saying this person is about to have something bad happen to her if we don't keep her on the radar and act, okay? So with no other strategy, that became our strategy. We were going to somehow build something that we will not let people go and leverage the fact that 20% of Americans drive 80% of the $3.7 trillion cost. 5% of Americans drive 50 to 60% of that cost. In our own health plan, 25,000 beneficiaries, 1.5%, less than 400 people, drive 30 million of our $130 million spent. So suddenly, you don't have to boil the ocean. You just have to identify the people at rising clinical risk and somehow give them a better outcome. Don't let Jane go through the summer and not come back. Let's get her butt back in here, even if we have to send someone to their house and beg her to come in and get that diagnostic mammogram and catch it at 15 millimeters, where her treatment would be what? Lumpectomy. Yes, it's cancer. Sentinel node biopsy. Negative. What's her treatment? Well, she already had it. We're just going to add a pill. Lumpectomy and a pill, and she's cured. I mean, which one is higher quality care at lower cost, right? Well, that is, of course. The only thing is, you might as well pull your Bic lighter out and start lighting up stacks of $100 million bills, okay? Because if you start providing care like that to people, where they actually have a better outcome, but they didn't come in, and we didn't get to do all that stuff to them that we get paid a lot of fee-for-service, dirty fee-for-service dollars, where's the economy? How do we win? How do we pay the bills, right? There is the cut point, gang. You either decide that fee-for-value is the right thing for your patients, and you're going to chase it no matter the economic cost, okay? You're going to build it so that you can surveil your populations, you can identify people at rising clinical risk, you can give them better outcomes and keep them out of the hospital, all right? Keep them from having bad stuff happen. Or you build new hospitals, okay? You build new hospitals in a community like Monroe County that already, with the beds that are in this facility for the trajectory for utilization, is overbedded by 100 beds. So we'll build a new hospital in that community with 40 to 100 beds. Think that was helpful? Yeah, sure. If you're chasing fee-for-service dollars, and you would put as many people as you can in those beds to get the money. And then if they actually require something more than basic med-surg care, send them down to the big facility where you get even bigger charge, okay? If you believe in value, what you would do is you wouldn't do that, okay? If you believe in value, you'd do what we just did in Schuylkill as an example. In Schuylkill, first thing we did, talk about a depressed economy. Oh my gosh. I mean, Schuylkill County has some of the worst disease in the state of Pennsylvania. They're top 5 in heart disease, top 5 in cancer, top 5 in everything bad, okay? That's Pottsville. First thing we did, put our own infusion center in for cancer care, okay? By the way, if you want to lose money, put a infusion center in right away. In largely Medicare and Medicaid, 8 out of 10 people walking in those doors are Medicare and Medicaid. Next thing you do to lose money, okay, is to take care of moms and babies. Build a brand new family health and birthing center and put it in there. Because 7 out of 10 of those babies are born to Medicaid parents, okay, if they have a mom and dad, okay? But if you're not taking care of moms and babies, you're not taking care of the community. You're not taking care of families. So that's the second thing we did. You get the idea? You make very different investments. You don't, by the way, in that community, build a brand new 80-bed hospital in the most densely commercially insured zip code, and there's only one, Orwigsburg, in the entire county, okay, and you build a brand new hospital. Cut me a break. You think that's taking care of the vulnerable issues that community needs? No, it's not. So you see the difference here? Okay, you either chase dirty fee-for-service dollars and keep building as many beds as you can and fill them up, or you're trying to have the back of the community and take care of them and give them the services they really need. By the way, transition now. I think you get the idea. We're pretty passionate about doing the right thing. By the way, is it successful? Can it be successful? It's going to be a journey. This is going to be a couple-decade journey. But I would tell you this. last year we made 130,000 phone calls to 21,000 people that we know are on our red hot list. All right? We've probably lost tens of millions of dollars every single year for the last 5 years by doing the right thing, but not having a contract with the commercial carriers to reward us for that. And even the federal government doesn't reward us for this. Okay? You have to truly change your economy so that your product is actually lower, has lower trend costs in caring for patients, and you can build that into a health plan. That's why Highmark wants to work with us. That's why all the sophisticated health plans want to work with us, because our trend costs are lower, because that's what health plans care about. Their number one most important person is an actuary that decides costs need to be down, and that's how you make care affordable over the long term. That's our journey. And this year, with a very mature population health platform, all the investments are all done. By October, every single hospital in our organization will be fully inpatient and out Epic. And just because people say they're Epic doesn't mean they're Epic. We have the full Monty, okay, in Epic at every one of our sites come October, because only with that data can you decide who are the people that are at rising risk. Pick them out, give them better care, give them a better outcome. And who wins? The patient gets a better outcome. The insurance company doesn't have to spend that money, all right? And we have better contracts that allow us to focus on giving better care to people, all right? One way of doing that in particular, and I use cancer example, because cancer is an expensive, expensive thing, all right? Every 2 weeks, every Monday, every other Monday at 8:15 in the morning, I talk to our brand new colleagues, 26 times a year. There's a picture I use to talk about Pocono. It's this building, okay? Why? Because it's cool. It's a cool building. But what happens here is beyond cool. So we had a lot of relationships with Pocono over the years. The most recent, before we merged, was we got a call and said, hey, listen, we have some trouble in radiation oncology. We could use a little bit of help. Do you think you can send anyone up to take a look? So, Keith Weinhold, who's our boss of our service line, or our institute, as we refer to it now, Cancer Institute, and Suresh convinced Charlie Andrews, who's the lead, he's an independent practitioner, but he's the lead on our radiation oncology associates that run all of our radiation oncology. Wonderful group of people. Imagine an MD that's also a physicist. Kind of scary, all right? All right, they are scientists, they have their discipline, things are supposed to be. So getting him to come up here to take a look was hard enough, and he was near retirement. He was going to cut down his practice down 2-3 days a week. Guess what happened when he came up? He never came back. Here's a guy who rarely do you see a smile, and he comes back, smiling, and says, you got to get up there. You got to invest in this place. This is fantastic. The people are awesome. The facility is amazing. By the way, they have a $30 million cancer center. $25 million of it came from local philanthropy. The community really cares. This is a special place. By the way, and this is where we all were like, really? He said, by the way, it's worthy of Memorial Sloan Cancer Center Alliance. We're like, wow. Because, there are only 3 places in America that are in that alliance. Lehigh Valley Hospital and Lehigh Valley Hospital in Burke, okay? Hartford Healthcare in Connecticut, and Baptist in Miami, and now Pocono. About 15 months after the merger, this place, we celebrated just downstairs with execs and top docs from Memorial Sloan Kettering came over here to say this place is worthy of that. And what that means, all that gets done here has to follow the right protocols that Memorial Sloan Kettering would follow. So I think that's a good transition. And we'll continue to provide really expensive, because it just is. It's just expensive. The cool things that are going on in cancer are expensive, but they're good for patients. So I think that's a good segue to talk to Suresh. And at the end, if you have questions, let us know. Hopefully you see the difference. You're a fee-for-service or fee-for-value. We don't want dirty fee-for-service dollars to take care of people for things that they should have never had happen to them in the first place. We're going to work hard for them to have healthier lives. And the money will work its way up. This will be our best financial year in our history, by the way. So is it working? We think it's working. Thank you.
Oh, I'm good.
Right, that's just your clicker.
Okay, great. Thank you, everyone. It's really a privilege coming here. My name's Suresh Nair. I'm physician chief of the Lehigh Valley Cancer Institute. I always enjoy hearing Brian give us the big picture. And what I'm going to do in the next 15 minutes or so is really show you all the excitement that's building in the cancer program here, both in our wider Cancer Institute, but also specifically here at Pocono. And a lot of what Brian talked about really resonated with me. I grew up in York, Pennsylvania, did my training at Jefferson, and I did my medicine at Geisinger, just down 80. And then I was at University of Pittsburgh for oncology. So it's actually this week, Charlie Andrews is retiring tomorrow after great, he really made a great contribution here. And I'll actually be finishing at the end of this week my 29th year as a medical oncologist in the community. The first 14 in Danville, and then the last 15 in Allentown, and now I consider myself a Pocono oncologist as well, because about a year and a half ago, as we were starting to work with the Pocono Cancer Program, I thought the best thing for me to do as the leader of the cancer program is actually come to Pocono, start seeing patients here. I was actively involved in recruitment of medical oncologists and surgeons to Pocono, and what an introduction, what a great year and a half it's been. What I've really learned is the Pocono community supports the medical mission, the community mission, more than any other community I've been in my 30 years. And you're just drawn to practice in this environment, and I've seen it from the patients, my patients that I've taken care of here in the last year and a half. So I'll start with this. I know, has everybody seen Prima's story on TV, on billboards and so forth? And I think Prima spoke at the Pocono Foundation, but her story is her mom is originally from Haiti. She had just started work as she went to Pocono School District, I think it's Pocono Mountain, and she had just started work at Cedar Crest as a medical assistant. And she went to, just as she was starting, it was around July last year, she thought she was starting to feel a slight lump in the breast. She's about 30, normally you don't worry about breast cancer at such a young age. She thought, oh, it's probably going to go away, it's probably a cyst. And then she started feeling it. Then she told a couple of her friends. They said, you really should get it checked out. It's nothing to fool around with. And then next thing you know, she said a week later, all of a sudden it's about 4 centimeters. At first when she felt it, being a medical assistant, she thought it was less than 2 centimeters. So she went to Bartonsville. It was a Friday. It was around end of the summer. And they instantly knew that this was likely to be malignant. They did a biopsy right away. They knew the biopsy would probably preliminary be back on Monday. Jen Henry, one of the wonderful APCs there, called me at Cedar Crest and said, you're going to be here on Monday. Could you see Prima? I'm going to give her the news likely on Monday. And if you can see her, we're not going to tell her we already prearranged an appointment. So I said, sure. And I saw her right across the hall. And at this point, it was scary. It was 6 centimeters now. So literally in a 2-week period, it was like doubling almost by week. So what we did, just 2 months prior to that, Pocono became part of Lehigh Valley Pocono, and the Dale and Francis Hughes Cancer Center became connected with the Memorial Sloan Kettering Alliance. So already just, at the time, we knew we were going to help people, but when you put a face on who you help, you realize why we do all this. So I told Prima that it was not a typical breast cancer. It was almost like a sarcoma of the breast. And in a young person, I said, there's aggressive mutations. We can't treat it like a typical breast cancer. So we're going to tap into the expertise. They have 1,000 oncologists at Sloan Kettering. In our Cancer Institute, we have about 50. We're subspecializing in a lot of areas. So we spoke to the team at Sloan. We did mutation testing, which is DNA testing called IMPACT. And we found that her tumor had a mutation called BRCA1. It's one of the breast cancer genes, but the breast cancer mutation can occur even when you don't have the inherited germline. We did germline testing, which is to see every cell in her body was fine. It did not have a mutation that would have predisposed to breast cancer, but we knew the BRCA1 gene is one that has to do with DNA repair. When you get random mutations, her tumor cells are growing very rapidly because of the BRCA mutation, some other mutations. but their vulnerability is that certain DNA damage you can cause to the cell, it would not be able to repair. So we picked specific chemotherapy. After 2 rounds, all the cancer went away. Actually, when her mom wanted to be there during the first course of chemo, which added another week. At that time, it was about 8 centimeters when we started. But luckily, she's cancer-free. She had a mastectomy after 2 cycles of chemo. She was cancer-free. She had a lymph node that was clear. And she finished more chemotherapy, had radiation downstairs, rang the bell, and she's told her story, and I think she's inspired the entire region. And this is really, our what we want to talk about is Hope and More, Dale and Francis Hughes Center, and the Memorial Sloan Kettering Alliance. So really, when we start talking about the Alliance, we started March of 2016, was the launch of the Lehigh Valley Cancer Institute at Cedar Crest and at Beulah, Burke. We had a wonderful celebration. The heads of Sloan came with all the TV cameras. Brian and I were there, along with Keith and others. So we've now finished 3 years, and it's really transformed our care. What it did is it brought a lot of new clinical trials, a lot of new technology, new ways of thinking, weekly tumor boards, some of which are being broadcast right into here. And then June 7th, 2018, we were downstairs for the wonderful Dr. David Pfister from Sloan and Paul Sabatini from Sloan were here. They were wowed. We gave them a tour of the facility, and Dave said, Suresh, I don't want to tell you this, but this cancer center looks nicer than yours in Cedar Crest. I said, oh, this is, we're as proud of all of this. So this was all the work. We had teams of nurses that had to look at all the things. Sloan basically wanted a report card. They wanted a lot of granular features. So how your lab was doing things, how medical oncology, how radiation oncology, how nursing, how the leapfrog safety came in the 7 years in a row, pathology, perioperative care, pharmacy, survivorship. And then they audited half of all the cases in the prior 3 years, I believe, in breast, colon, endometrial, kidney, lung, and prostate. And then we got a report card. The report card actually came in quite good. We had some remediation that we had to do, and then by last summer we met all the criteria. In the last year and a half, we've been on a journey to continue to expand our team because we know that the community needs more and more care. So Dr. Sonia Shen had been in place when I came here. She's a fabulous oncologist who moved here from Easton. Is doing a phenomenal job. Dr. Patel and Dr. Koh, we recruited in. Dr. Patel's been here since last fall, Dr. Koh since last summer. Dr. Patel had just finished his fellowship at Oxner in New Orleans. He had already had a job at Ohio State at University of Louisville. He was a budding transplant physician, hematologist. He also had a job at St. Luke's and Geisinger, my former place. He believed in the vision of what we're building here. Dr. Koh has a master's in public health from Harvard. He also has his fellowship from Boston University. Had been practicing in Long Island, and Sloan actually built a new center right down the street by the Nassau Coliseum. And Dr. Koh saw the writing on the wall. He said, I'm moving to Lehigh Valley, Pocono. I'm here on some Mondays, and Luciana is a wonderful nurse practitioner. She had been she's a pediatric nurse initially and then became an NP and had been running the breast navigation program. And so we're very proud of what's happening in surgical oncology. Initially, right after the MSK announcement, at the edges, we have Dr. Brodsky's on the top left, Dr. Aaron Blackham on the top right. They're two of our top cancer surgeons, surgical oncologists. They started coming and seeing patients here on Wednesdays to help with the tougher liver cancers, with pancreatic cancers. Aaron's also a melanoma specialist. And then on the bottom is Dr. Martino and Dr. Thomas. There are two gynecologic oncologists, phenomenally trained. All of these surgeons are robotic surgeons, some of the best in the country. Our goal is this is a short-term transition as we continue to build at more and more expertise, and we'll keep working with the teams. So Dr. Krista Bott is a phenomenal breast surgeon. She started back, she did part of her training at Lehigh Valley Cedar Crest. She's from Scranton area. Started back here and has been doing a phenomenal job in breast oncology. Christine Kim was known to the community. She trained at Sloan Kettering, and her first job was at Jefferson 5 years ago. And actually, Steve Cunningham and Bill, I think you worked in bringing her here to see patients 2 days a month. Christine loved the community. We started a 6-month recruiting her. It was like recruiting a 5-star college athlete for, like Coach Franklin, who used to be down the street. So we wouldn't let Christine go. She was not that happy at Jefferson. She was very much of a rising star in the GYN oncology. And she started seeing the research potential. She saw the alliance happening, and she decided in February to come here. And she's actually starting August 5th. Phenomenal researcher and phenomenal bedside manner. She's skilled in all the latest robotic techniques. There's a new robot attachment, I guess, is going to come to the OR for Christine. And then Charlie, it's too bad we should have had Charlie's picture on here as well, but my team made this. Dr. Sean Quinlan Davidson is the kind of the head of radiation oncology, trained at MD Anderson, phenomenal radiation oncologist. And Charlie Andrews' replacement is, which he and Sean and others picked. We had very intense competition. There were 4 of the top radiation oncologists wanted the job. It's Dr. Naburi, who trained at Drexel and at Jefferson, and he's he actually got the 2015 Young Oncologist grant from the Radiation Oncology Society. Very good bedside manner as well. So Charlie made a very smooth handoff with Dr. Nabori practicing downstairs starting next month. And so in the last year, we've done a lot, but we're going to, things are just accelerating. So I'll finish with some of the things that we've done. We chose the beautiful Pocono area, actually Camelback Lodge, for our annual symposium. We had our first one in October 13 of 2017. We had a wonderful turnout, actually. Dr. Foster, quite a few of the primary care physicians from Pocono were present. We actually had Memorial Sloan Kettering speakers as well. Dr. Paul Sabatini was there. And really we started, Brian, using the word partnership even before. And so I know we've been partnering for quite a while. And so we came back to Pocono last year, November, and really the foliage was even better than the photo here. And this is really our, these were all primary care physicians, some oncologists from the community. And it was really very lively, a lot of interaction. We actually got a lot of feedback on how to make the lung cancer nodule screening program better, right, Keith? And we incorporated a lot. It was bi-directional learning. And at the right corner, we're a team from Sloan Kettering here, both years as well. And so now we're in the process of opening the clinical trials. So clinical trials are really the lifeblood of new innovation, new treatments. These are mostly medicines that aren't yet FDA approved, but can be life-saving. They're being compared to standard of care. Just to give a frame of reference, in the community, a very good community program would have maybe 50 clinical trials open, and there may be about 50 of those in the whole country. Lehigh Valley was at that level 3 years ago. Now we have 200 clinical trials open and increasing. We're in the process, so technically all of our trials are open to Pocono, at the Dale and Francis Hughes Center. So we're in the process of developing the infrastructure to be able to capitalize on all of them. So our clinical trials director, Morgan Horton, comes here. Monthly, she and I come here, meet with the physicians, and we're launching trials. The first trial at Pocono is a trial for breast cancer survivors. And it's really a trial that's looking at once you're done breast cancer treatment, surgery, chemotherapy, radiation, sometimes weight gain is part of that because of change in hormone levels from the chemotherapy. We're finding now that exercise, by keeping BMI down, lowers estrogen level and can have as much of a beneficial effect on long-term health and decreasing recurrence as taking tamoxifen can. So we want to do both. So this is a very neat trial where the standard arm 1, they get the standard education. They're told to bring their BMI down to ideal, taught about nutrition, and they see their oncologist. The arm 2 is an intensive supervised weight loss intervention, and it starts with they get a free Fitbit, they get a scale. They're electronically, digitally managed by the study team in Boston, and so they are followed very closely for that. After 2,000 patients, they've already found that the arm 2 is achieving its objective. It is leading to improvement in BMI. It is leading to improvement in some of the health outcomes, but we don't know about breast cancer survival yet. So they've gone on to 3,000 patients. The very one of our patients right here went on Be Well, and they're recruiting for more patients. So this is a kind of a prevention health. The next one is a lung cancer trial. We don't need to get into all the science, but it's really using the DNA testing to give the best preventive treatment to give a higher cure rate for early stage lung cancer. And the third trial is a breast cancer trial. It's actually bringing this immunotherapy drug called atezolizumab for the first time, adding it to the preventive treatment. This trial just opened nationally about 2 months ago. It's already open here. So, and we're just getting started. So this is a very, very cool trial. This is a genomic DNA-based trial, and it's a private company called Strata Oncology. Now, this one did not start at Sloan. This started at Mass General Hospital in Boston and University of Michigan. And they found that the biggest barrier, so, if somebody has advanced cancer, stage 4 cancer, if you do a deep mutation testing, 500 genes, about a quarter of those patients, you'll uncover a mutation that we can give them an experimental pill that can go inside the tumor and turn it off. It's hard, like a smart bomb, a smart pill. The problem is, to do this testing, patients may have a copay of as much as $5,000 through the commercial. It may be nothing, it may be high, but patients are uncertain, and about probably half our patients say, I don't want to take that risk for my family. I have advanced cancer. And so this Strata is overcoming this barrier by basically doing the genomic testing for free. But their motivation is they want to profile about 100,000 patients to find these 1% mutations, because that's the only way the companies these new biotech companies that are developing these medicines, they want access to that 1% of patients that have the mutation who are scattered all over the country. So they picked 18 of what they think are the top cancer centers. So our cancer institute made the cut of one of the top 18. So this is independent. So Sloan said, oh, Strata picked you because Sloan is, I said, no, you're still our number one, but we're going to do this also. And Dave Pfister, that's great. We don't want to stand in the way. So what's in it is tomorrow we're having the final education, and it's launching at Cedar Crest in Muhlenberg on next Monday, July 1st. Right after Epic Go Live, we're launching it here as well. There's a lot a lot of regulatory things that require Epic for this. So all of our patients will basically not have to worry about the cost of testing. And there's about 20 free drugs that are part of this Strata clinical trial. We have Dr. Shin is our medical director of cancer genetics. Candace Peterson, who's our director of, this is about genetic risk for cancer. She had started video genetic counseling, but now she started coming here on site because of the need. And Caroline McConnell is a phenomenal nurse navigator for both genetics and breast cancer. And this is why we do all this. We had a big gala across our entire cancer institute. It was March 30th, and at the end of the gala, Dr. Martino, I see our team got to take a picture with all of our survivors. Prima is there to the back. There's several survivors from Pocono in this picture. And our goal is to, and this, we have a lot of celebrations. We have a celebration almost for every month. And this, believe it or not, is a group of stage 4 kidney cancer survivors. This was this year in April. And we had almost 35, 40 stage 4 kidney cancer patients celebrating their survivorship. So we're very proud of what's happening at the Dale and Francis Hughes Cancer Center. We're proud of what's happening across the Institute. I think as much progress as we made last year, I think we'll make 5 times more this year because a lot of the hard work's been done. And now we're having, I didn't even get to tell Brian this, just last week, I got a call from a couple that are finishing their training at the Mayo Clinic in oncology. The husband is, he's from California, has been at Mayo the last 5 years. He's finishing next summer. His wife, they met, she's from the Midwest. They met at Mayo. She's an oncology hospitalist. He's a hematologist oncologist. He's coming out here. They're coming out here as a couple to look at Lehigh Valley Pocono because he talked to the recruiter. He said, I really like the outdoors in Pocono where I know it's got everything. It's got clinical trials. It's got Memorial Sloan Kettering. A couple of my partners said he doesn't want Cedar Crest. He's coming from Mayo. Nope, he wants Pocono. So we're really going places. Thank you, though, to the community for all the support.
Before we wrap things up, I would encourage, if any of you have questions for either Dr. Nestor or Dr. Nair, anything about what you heard today that you may like a little explanation on, I'll invite you to ask those now.
Any hard questions, we'll get to Elizabeth.
Exactly.
You use the term EPIC a few times. What is that?
EPIC happens to be the name of our electronic medical record system. Yeah, it is the most popular one in America. There are a couple statistics that over half of all patients are connected to a doctor who uses EPIC. So talk about a monopoly. It's the monopoly in healthcare.
So is that the system that will eventually eliminate you from having to answer the same question over and over again?
Supposed to.
Yes.
I have 2 questions. One is about EPIC. Will you be adding on additional staffing in order to get all this completed by October?
Do you want to take that?
Yeah. And Bill, you can jump into.
Believe me, there's a plan.
So yes, there's an intensive plan that involves not only a lot of education that we'll all go through and different amount of hours of education associated with it, but when we go live on October 1st, we will have at the elbow support of EPIC users from across the network are coming here from all different areas because it's not only it's the cancer center, it's the hospital. Our physician practices went live a couple years ago, so they're already live on EPIC. And we will have a command center set up, so there will be resources here, at least initially for 2 weeks of intensive, because that's usually the time frame. It usually takes about 2 weeks for people to get acclimated, and then it'll ramp down over an additional 2-week period. But yeah, 2 weeks prior to the go live, 2 week post and beyond, we will have support of people who are currently using it across LVHN. They will be here on site with not only our physicians, our nursing staff. We also have identified what's called super users. So there are our own staff that get even more additional training so that they will be freed up and available to help support our staff. And remember, that's 24/7 because obviously we're open 24/7. So yes.
Yeah, thank you. And then my second question is, did I understand it's called Stop the Bleed?
Yes.
BLEED?
That's
is this
correct.
For, like for schools for active shooting? Is that what? Are you thinking about expanding that to businesses? Because that's also an issue for corporations.
Yeah, we have not done that yet for businesses. We really wanted to focus in on the schools initially, and then outfitting our security officers that are in the schools with tourniquets to stop bleeds. But that's something certainly we can take a look at because it's a national, campaign, and it really involves getting the kits. But more importantly, you can have the kit, but you have to know how to use it. And so it really is training and educational support, which we can provide. So we can talk a little bit more about that.
Any other questions? Yes.
Dr. Nestor, in your talk, you spoke about, what do I need that for? I already had lunch. You spoke about value, the service for value, which is a great idea. Nobody in this room would argue with that. Then in that same sentence somewhere, you said that financially, that we are as strong as it's ever been now. You did say that, right? Would you say that the reason for being financially strong is because of this value, or is the community stepping up, giving a lot of donations that are helping financially? What would be the main reason for that?
It's definitely not philanthropy, all right? And that's not a slam on philanthropy. We are doing, just in context, Lehigh Valley Health Network is doing a $100 million capital campaign right now. The Pocono region has their own foundation, so any donations that come to the Pocono region go through the foundation. But when you think about a $100 million capital campaign over 5 years, philanthropy is a rounding error, okay? No, it's meant to fund things that we would otherwise have a hard time funding through operations. Critical, okay? It's a very important $100 million, but that's not what floats the boat. What floats the boat principally is that value equation. V equals quality divided by cost. The biggest driver of that right now is cost reduction. Okay? So we are working tirelessly on taking, before we merged with Pocono, we were taking $50 to $60 million out of our cost every single year because the payment was ratcheting down and the cost of care was ratcheting up. Even on our own health plan, we saw a 28% increase in prescription drugs for Dr. Suresh and his family and my family. We're not immune from those costs. So we have the same challenges as a self-insured employer. Taking cost out of the company is really hard because we've been doing the same thing every year to reduce it. At some point, you get down to humans because that's the easiest place to go. The easiest place is to take people out of the system because they're 50+% of our overhead. We don't want to do that because we think that our care, fee for value care, is humans taking care of humans, right? So if we start going there, we're going to erode what we're all about, all right? So it's a really hard thing to do, but we're in the middle of a 3-year journey. We finished the first year of taking $250 million out of the entire network using the consultant called Navigant. That's one body of work. We are also leveraging Epic, all right? When you are able to walk in and look at all the work that has to get done on a single platform, you can start changing dials and turning dials to be more efficient. So efficiency is a huge piece, taking waste out of the system and just costs we don't need. When we rolled out Epic just in the Lehigh Valley, we closed 300 software applications. Epic replaced 300 software applications, okay? So, and there's licenses to those, and there's upkeep and all that. This past year, we took $9 million of IT cost out of the system just by leveraging Epic. And by the way, in the same period of time, we added 60 employees. So we think we're only as good as our employees. We refer to them as colleagues, okay? Not employees, because colleagues are team players. We're all in this together. So that 26 times a year that I do that colleague orientation, the smallest group we've had is 40 people. We just had another one for 140 people. All right, that's 26 times a year. So we're growing. We have more people, but we are closing certain jobs and adding different jobs because healthcare is changing that fast. Finally, why are we having the best possible year? It's definitely about cost, okay? It is not about new admissions to the hospital. Here's the evidence. So this past year, we are going to end this year with inpatient activity flat year over year, flat. In a normal fee-for-service health system like ours, that's a sign of death, okay? It's flat. All right, our competitor is up. Of course, when you build brand new hospitals all over the place, Quakertown, Schuylkill, Monroe County, you're going to wind up adding more people into the hospital system and drive it. But if you're working hard to keep them out of the hospital, all right, you have flat admissions year over year, despite a growing demographic, right? We had a 65% increase in Medicare eligibles across this region. I mean, there's a whole lot of reasons for us to have more and more people in the hospital all the time. So imagine that. We've kept it flat. That's by keeping people out of the hospital doing different things. So the last piece of this that gets us to the best year ever, the biggest piece is cost. I call that 85 to 90%. The other 10 to 15% is this burgeoning value payment that we're now beginning to get. How's that work? Look, if we take $100 million of business, all right, person comes in the hospital, has to be intubated for congestive heart failure, goes to the ICU, has a cardiac cath, has open heart surgery, you know, a bunch of people like that, $100 million book of business, right? If we prevent that from happening, just light it on fire, $100 million. Where's that money go? It stays in the bank of the insurer. Okay, didn't get spent, didn't pay us. So we've got $100 million that we didn't get. Had we done that $100 million worth of work, our overhead is 97%. We would make on our operating income $3 million, okay? So really all we really need to keep the place going to invest in next year, okay, is $3 million on that $100 million of work. So they could just give us a check for $3 million and we'd be hold harmless. Problem is you can't keep doing that because you have a fixed overhead, all right? So what we're really doing is saying we're negotiating between the $3 million and the $100 million. Better rewards if we better manage the population, and we're willing to go risk. We have a product with IMARCs coming out in January. We're full risk for populations. Bring them on. We will keep them out of the hospital. We will reduce the trend costs and reward us on that basis as opposed to rewarding us for doing unnecessary mastectomies. You know, so right now, that is our opportunity. It's a new lever to make money, okay? Or make enough money to sustain the organization in good dollars, dollars that are giving better outcomes. That's going to take about a decade probably for us to get there. But the pool of dollars is growing every year. 3 years ago, $13 million. 2 years ago, it was $20 million. This past year is $29. We're budgeted $49 million. So that should be at about a $100 million pool of value-based rewards if we better manage populations. And I think that's I'd rather make our money that way than make it on how many people can we get in. You know, going to bed each night hoping the hospital beds are full is kind of perverse. You know, we don't want it to be full. We want people at home, you know, getting good care and staying out of us. Thank you.
In the interest of time, I'm going to wrap it up. If there are no more questions, I want to thank our speakers today for joining us. I also would encourage all of you, if you are not a member of our Board of Associates, I have applications over here. Come see me after the meeting. We hope to grow our Board of Associates here in the Pocono market to about 75 by this time next year. I appreciate you all taking time out of your day to come join us, and thank you again to our guests.
Thank you.